Good morning, one and all. This morning we will be just discussing an overview. चलेगा ना जैसे मैं ये रखता हूँ वो वैसे कहाँ देखना है राइट ऑडियो ऑडियो हेलो Good morning one and all. This morning I will be just giving you an overview of all the topics which were recently seen in AIIMS S.R.Ship exam held on 11th of January this month. Basically, the questions which were asked were from selected topics, though they were not straightforward questions. They were indirect questions, mostly of some postgraduate levels. So all we need to know is brief overview of all the topics in detail which were mainly discussed in those questions. The topics are simple. The main topics which were asked were trauma, the hardcore for AIIMS, next were TMJ, few on orthognathic, then cyst and tumors, very few questions on local anesthesia, and lastly salivary gland disorders. Trauma from AIIMS point of view, all India point of view, which is going to be held of 25th of Jan, you need to be well versed with the entire trauma as far as maxillofacial is concerned. Mostly the questions I will be discussing, the theory I will be discussing, mostly are going to be repeated in all India. That's the main aim of this lecture which we are taking. So just focus on the topics I have mentioned, mainly trauma and TMJs, out of which most questions are based. Starting with trauma, I will just give you an overview of all the trauma, all the areas of trauma discussed in this S.R.Ship exams, plus a few related questions asked to the topics. Starting with middle third fractures. In middle third fractures, they had mainly focused on Leaford 1 and 2 and 3 fractures. You should be well versed with all the lines of Leaford 1, 2 and 3. And out of that, some postgraduate level questions were asked, like the approaches taken to approach these fractures. Like for Leaford 1, 2 and 3, you need to be well versed with the lines. Like Leaford 1 starts with the piriform aperture, then comes the lateral wall of maxilla, going to the zygomatic buttress. The line turns posteromedially to the pterygoid lamina, getting its disjunction at the upper 1/3 and lower 2/3. Simultaneously, in Leaford 1, there is one more line which passes through the palate, causing disjunction of the dentofacial unit of the maxilla. Then comes the signs and symptoms. The main signs and symptom you need to know from MCQ point of view is the cracked cup sound heard on palpation of Leaford 1 fractures. How to approach Leaford 1 fractures? The main approach is vestibular incision for maxilla. Bilateral vestibular incisions are given. That is the only approach we have for Leaford 1 fractures. Coming to Leaford 2 fractures. Leaford 2 fractures, also called as pyramidal fractures. They start from frontonasal suture, cross the zygomatic or maxillary junction, the anterolateral wall of maxilla till the zygomatic buttress. Another line crosses the lateral wall of nose, going across the hard palate to the pterygoid lamina. This causes the disjunction of the maxilla in a pyramidal fracture. Hence, it is called as pyramidal fracture. How to approach this fracture? Mainly, there are a number of approaches to view this fracture. Like for frontonasal junction, we have bird's eye view, we have the gull's view, we have the open sky approach. These are the approaches, out of which in AIIMS S.R.Ship exam, one question was asked, the main approach incision for nasal fractures or the frontonasal sutures. The answer is gull's eye view. Okay. Then comes the second part of the Leaford 2 fracture, the frontomaxillary junction. How to approach the frontomaxillary junction? Obviously, maxillary vestibular incident, intraoral maxillary vestibular incident. Coming to Leaford 3 fractures, all you need to know is the fracture line starting from the frontonasal suture, going medially across the lacrimal bone till the infraorbital fissure. Then the line goes laterally and causes frontomaxillary disjunction. Main thing you need to know in Leaford 2 fracture, as far as the signs and symptoms are concerned, is raccoon eyes plus Dystopia. Dystopia is altered orbital level seen in Lefort 3 fractures. Why is this dystopia? Because of disjunction of frontomaxillary suture, which causes inferior placement of the Whitman's tubercle, causing inferior placement of the globe of the eye. How to approach a Lefort 3 fracture? Again, the frontonasal part can be approached via nasal incision, as I discussed earlier, the girl's eye view, the open sky approach. As far as the frontomaxillary junction is concerned, we can go from the lateral brow incision or the incision across the fracture, or the most commonly laceration which is seen over the fracture, that can also be used as an approach area for frontonasal junction, frontomaxillary junction. These are the Lefort 1-2 fracture lines, their signs and symptoms, and the approach area. Now coming on for the approaches which are mainly used to approach the middle third of the skeleton. The main approach they had asked for is the naso-orbital ethmoidal fracture. Okay, and again we have the same approaches for NOE fractures. We have the girl's eye view, we have the open sky approach. These two are the most commonly used approach. Then for supraorbital rim fractures, we have the supraorbital incision, upper eyebrow incision, lateral brow incisions, which are most commonly used to approach the supraorbital incision. Then comes the infraorbital fractures. The incision most commonly used to approach the infraorbital fractures are infraorbital incision, subciliary incision, transconjunctival incision. These are three of the most commonly used incisions. Then coming to maxillary fractures like Lefort 1, 2, 3 fractures, the most common incision used is the vestibular incision, intraoral vestibular incision for Lefort 1 and 2 fractures. Then coming on to zygomatic, ZMC fractures, that is the trifort fractures. The most commonly used incision for ZMC fractures to relocate the ZMC fractures are the Gillies temporal approach incision, which is the most commonly used incision, which is given at an angle of 45 degrees to the zygomatic arch, going obliquely upwards and anterior. Okay. Okay. Then is and Gillies temporal approach to approach the zygomatic-maxillary complex fractures to relocate the displaced fractures. It is an incision given at an angle of 45 degrees to the zygomatic arch, going upwards and superiorly. Okay, so we are done with the approaches to nasal bridge, the infraorbital rib. Now comes the subcondylar fractures. A question was asked in this exam for subcondylar fractures. The most common and easy approach for subcondylar fracture is, the options given were submandibular incision, post-ramal Heinz incision, pre-auricular incision, and Alcath and Bramley incision. So let's go into the detail. As far as Alcath, Bramley and pre-auricular incisions are concerned, those are the most common incisions taken to approach the condyle, not the subcondylar region. I'll repeat again. Those are the most common incisions taken to approach the condyle, not the subcondyle. Okay. Now, those incisions are also taken most commonly to release ankylotic masses in cases of TMJ ankylosis. Now, we are left with two options, that is the submandibular incision or the post-ramal Heinz incision. For submandibular fractures, to reapproximate the fracture segment and to plate across, the most easy and accessible incision remains the post-ramal Heinz incision. Submandibular regional incision also taken. The only disadvantage it carries is we need a good amount of retraction. The fracture has to be way below the condylar level, and a few difficulties are encountered during the plating of the fracture. So the answer remains post-ramal Heinz incision, which is the most common incision taken in cases of subcondylar fractures. Coming on to symphysis fractures. If there is any existing laceration in a case of trauma encountering in symphysis fracture, then the most common approach area for this fracture remains the existing laceration. If there is no existing laceration, all we have is the vestibular approach to approach the symphysis of the mandible. Now, in vestibular approach, also called as degloving incision, it is taken in the depth of the vestibule, taking care of the attached gingiva. Now, the question asked in AIIMS S.R.Ship exam for the vestibular incision was, after a vestibular incision is taken, the first step during the closure of this incision is, the options given were to suture the periosteum, to suture the mucosa, to suture the periosteal stubs, to suture the muscle stubs. The answer remains to suture the periosteal stubs. To avoid which stin? What happens if you don't suture the periosteal stubs? Periosteal stubs are basically seen in the depth of the incision. If you don't suture those, then all the patient has is chin drop, or we also call it a witch chin, which resembles a witch. So we have to address that periosteal layer first, then we can come across the muscle layer and the vestibular layer. As I discussed earlier, from MCQ point of view, for Leaford 1, we need to be well versed with the cracked cup sound, which is heard on percussion in Leaford 1 fractures. And as far as Leaford 2 fractures are concerned, we have subconjunctival hemorrhage seen in the medial canthus. Subconjunctival hemorrhage seen in the lateral canthus and seen in cases of Leaford 3 fracture because of craniofacial disjunction. In Leaford 2 fractures, we also have something called as infraorbital paresthesia, which is also seen in Leaford 3 fractures. In Leaford 1 fractures, we don't have any infraorbital paresthesia or subconjunctival hemorrhage. Going on to our next slide, something I'll discuss about orbital apex injury. What is orbital apex injury? Seen mostly in cases of high energy trauma, most commonly seen in children, because the apical part of the orbit is not well developed in these children, mostly in the age group of 5 to 6 years. So any high energy impact on the globe from outside creates a great amount of intraocular pressure, which leads to orbital apex fracture. It is yeah. Roll number 705170 has asked the sutures the periosteal. I'll just review again that question. The options given, the question was vestibular layer in cases of symphysis fracture. The first layer to be sutured is the periosteal layer. The periosteal, second option was the periosteal stub in the depth of the vestibule. Third option was suture the muscle layer. Fourth option was suture the vestibular layer. So the answer remains, the answer is suture the periosteal layer in the depth of the vestibule. Why that is the answer? Because if we don't suture the periosteal layer in the depth of the vestibule, the patient will have something called as witch chin. There will be a chin drop. So to avoid that, we need to suture the periosteal layer in the depth of the vestibule. The next question which was asked by roll number 501074 was, which incision is in subcondylar fractures? The question asked was, the most common incision taken to approach the subcondylar fracture is, the options given were post-femoral Heinz incision, submandibular residence incision, preauricular incision, or the Alcaic-Bramley incision. The last two incisions, that is the preauricular and the Alcaic-Bramley incisions, are mostly taken in cases of TMJ ankylosis. So those two are out of option. The other options which we are left with is the post-femoral Heinz incision and the submandibular residence incision. Submandibular residence incision is out of question because it is an inaccessible area for the subcondylar fracture. The plating becomes difficult. So the only option we are left with is post-femoral Heinz incision. Okay. Coming on to orbital apex injury, as I told earlier, it is seen mostly in children due to high energy fractures, high energy trauma, which causes increase in intraocular pressure, leading to orbital apex injury. Now, in orbital apex injury, the posterior part of the orbit containing the optic nerve, the superior orbital fissure, and the neurovascular structures are damaged. So the signs and symptoms by default are going to be related with all these. The common sign and symptom will be loss of visual acuity and loss of vision. After that, we will have something called a superior orbital fissure syndrome, and damage to neurovascular substructures will obviously cause paresthesia in this region. And it is mainly seen in children. So the question asked in orbital apex injury was, incorrect about orbital apex fractures. Incorrect about orbital apex injury fractures was, it is uncommon in children, option number 1. Second option was loss of vision. Third option was uncommon in adults. Fourth option was treatment to be done in adults. As far as children are concerned, it is seen mostly in children. So uncommon in children, the A option is the option of choice. Second option is loss of vision. Obviously in orbital apex injury, there is a loss of vision, there is a loss of visual acuity. Third option is it is uncommon in adults. Correct, it is uncommon in adults. The last option is treatment to be done in adults. Yeah, the treatment has to be done to correct the visual acuity and to protect the neurovascular bundles. So the answer of choice in orbital apex injury is, which is what is incorrect, is it is uncommon in children. Okay. AIIMS S.R.Ship had also focused on something called as naso-orbital ethmoidal fractures and frontal sinus fractures. These two are the areas or the topics which usually at the graduate level we avoid. Those are not given in the most commonly seen books of oral surgery. So I'll just give you an overview of what are frontal sinus fractures, what are naso-orbital ethmoidal fractures. These are some of the postgraduate questions which they had asked, and they can be repeated in the All India exam which is coming next week. So I'll just classify the frontal sinus fractures. Basically, frontal sinus fractures are seen in low energy or high energy fractures, both seen most commonly as depressed fractures of the skull. To classify in short, we have anterior table fracture, we have posterior table fracture. Posterior table fracture is more to be taken care of because it is directly related to the cranial structures. Anterior table fracture can be addressed without any intervention or can be intervened with surgical methods. Okay. In anterior table fracture, we have anterior table fracture with or without displacement. We have anterior table fracture with or without outflow tract injury. That is a nasofrontal tract injury. In posterior table fracture, we have fracture with or without displacement. We have fracture with or without ductal injury or CSF leak. We have posterior table fracture with or without outflow injury. So this is just an overview of the classification of frontal sinus injuries. What are the basic principles of management? So the basic principles of management for frontal sinus injury fractures are: re-establish the frontal bone contour. As I told earlier, it is a depressed skull fracture. So the first point we have to take care is re-establish the facial bone contour. Second is restore the sinus mucosa and maintain patency of the nasofrontal duct. This is very important. We have to restore the sinus mucosa, or we will encounter something called as mucocele or mucopyocele, and we have to maintain the patency of the duct. If patency cannot be established, eradicate the sinus mucosa and remove the duct. Very important. If the patency of the nasofrontal duct cannot be established, remove the sinus mucosa and remove the duct. Above all, if we encounter something called as posterior table fracture, in which intracranial structures are seen, in those cases we have something called as obliteration. Now what is obliteration? Obliteration is just obliterating the sinus mucosa with fat or bone, which acts as a barrier between intra and extracranial systems. To protect the intra and extracranial systems, not to make them in contact, we obliterate the frontal sinus. This obliteration has to be done in cases of frontal sinus fracture with posterior table fracture. Okay. The most common approach for frontal sinus remains the coronal or the bitemporal approach. Very important from MCQ point of view. The most common approach for frontal sinus fractures is coronal or a bitemporal approach. Now the question asked in AIIMS S.R.Ship exam for frontal sinus fractures was: for obliteration of frontal sinus, all are correct except, I'll repeat, for obliteration of frontal sinus, all are correct except option A was done with fat or bone, option B is done in anterior table fracture and obstruction of frontal nasal duct, option C was done in posterior table fracture, option D was done in comminuted fractures. Now we'll go in detail of each of the options. As far as option they have asked is what all are correct except as far as obliteration of frontal sinus is concerned. Option A remains done with fat and bone. It's obvious obliteration is done with fat and bone. Then this option is out of question. Option 2 was done in cases of anterior table fracture, and obstruction of frontal nasal duct. Obliteration is not done in cases of anterior table fracture because anterior table fracture we just need to take care of the contour. We just need to re-establish the facial bone contour. So this also option is also an option of choice. Option C was done in posterior table fracture. Right. Frontal sinus obliteration is done in cases of posterior table fracture. Option D was done in comminuted fractures. Obliteration of frontal sinus fractures is obviously done in cases of front comminuted fractures. So all are correct. It is done in with fat or bone. It is done in cases of posterior table fractures. It is done in cases of comminuted fracture, except option 2, that is done in cases of anterior table fracture. Obliteration is not done in cases of anterior table fracture. Now, what are the materials used for obliteration? We can use autogenous graft materials like fat and bone, as I discussed earlier. Then after that we have pericranial fascia, we have muscle, we have cancellous bone, and lyophilized cartilage, which can also be used at times. The best material of choice for obliteration in cases of posterior table fracture remains fat and bone. Moving on to our next slide. Blowout fracture. Now, what are orbital blowout fracture and why do they happen? The inferior wall or the roof of the maxillary sinus, inferior wall of the orbit or the roof of the maxillary sinus is a thin fragile wall, which is the main area of trauma, which is the main area encountered in trauma in blowout fractures. Now, in high energy impacts to the orbit, there is increase in extraocular pressure, which causes either orbital apex injury or fracture of the orbital floor, leading to herniation of the fat and muscle mass, causing entrapment of the globe. Okay. Now, from MCQ point of view, in blowout fractures, all we need to know is there is enophthalmus with reduction of ocular movements because of entrapment of the inferior rectus muscles. There is enophthalmus and reduction of ocular movements. There is diplopia. Obviously, the extraocular muscles are entrapped. There has to be diplopia, that is double vision. Diagnosis, very important. Diagnosis of blowout fracture is done with something called as hanging drop sign, seen mostly in PA Waters view. The radiograph for blowout fracture remains PA Waters view, in which we see hanging drop sign for orbital blowout fracture, and the best reconstruction material available till date for orbital blowout fractures is titanium mesh, which we adapt and fix to the inferior orbital rim to support the globe. Now, the most commonly asked question in blowout fractures will be the radiograph of choice, the radiographic picture of blowout fractures. Then comes your best reconstruction material of choice used for treating these fractures, and the approach. The approach remains the infraorbital approach or the subciliary approach, as I told earlier, to approach these fractures. And the question asked in this S.R.Ship exam as far as blowout fractures are concerned was the best reconstruction for orbital floor fracture, that is a blowout fracture, is the options given were titanium mesh, bioresorbable plates, reconstruction plates, or all of the above. As I told earlier and in this section also, the best reconstruction material of choice remains the titanium mesh. So the option is answer A, that is titanium mesh. Going on to the next important topic, which obviously at the graduate levels students are not well versed with, is something called as NOE fracture, that is the naso-orbital ethmoidal fracture. Now, naso-orbital ethmoidal is a junction at the roof of the nose, which is a fragile area seen in cases of low energy trauma. Low energy trauma to this region causes combination of these fracture segments. The three bones involved in these fractures are the nasal bone, the orbital bone, that is the lacrimal bone of the orbit, and lastly the ethmoidal bone. Now, all you need to know as far as MCQs are concerned from your exam point of view is the intercanthal distance. Intercanthal distance is half of the interpupillary distance, which is near to 30 to 35 millimeters. Now, why we need to know the intercanthal distance in NOE fracture is, in NOE fracture, the medial canthus of both the orbits is displaced, or we can say those are avals, leading to something called as Telecanthus. Telecanthus is increase in normal intercanthus distance. Okay. Now the most important step in NOE fractures is to restore the intercanthal distance. It means we need to restore the medial canthal ligament of both the sides to restore it to normal values, that is 30 to 35 millimeters. Okay. Now coming on to the next point, those are the approaches for NOE fractures. As I told earlier, the girl's view or the open sky view to approach the nasal fracture, the medial brow incision or the superior brow incision to approach the ethmoidal fractures. These are the two most commonly used approach for NOE fractures. And lastly, the most easy and the most accessible approach to approach the NOE fractures will be the coronal approach. The coronal approach or the bitemporal approach is also used to approach the zygomatic arch, the supraorbital rim, the nasal floor, the nasal roof, and the lateral part of the infraorbital rim. Coming on to the classification. This classification is mostly of a postgraduate level. I'll just give you an overview. The Markowitz and Manson classified the NOE fractures as follows. Type 1 NOE fracture in which the medial canthal tendon is intact and connected to a single large fracture segment. I'll repeat again. Type 1 NOE fractures are in which the medial canthal tendon is intact and connected to a single large segment. Type 2 NOE fractures are the ones in which the fracture is comminuted. Okay. In type 1 the fracture is not comminuted, in type 2 the fracture is comminuted, but still the medial canthal tendon is attached to the comminuted fracture. Coming on to type 3, comminution extends to the medial canthal tendon and the medial canthal tendon is avulsed. In this